and welcome to Affected, a podcast from Meet. For those of you who don't know Meet, we are a global life sciences talent provider. We've been connecting the industry for over a decade, and now we want to share some of our insights and experiences with you. We'll be hosting monthly episodes, sharing thoughts from our leaders and industry professionals about job hunting and hiring in life sciences, as well as giving our network a platform to share their own experiences of building successful careers in an industry that affects us all.
Hey guys, and welcome to another episode of Affected. I'm once again joined by the king of LinkedIn himself, Mr. Glenn, the man who pays my bills, Southam. And I am so excited to introduce you to Ioana Cretu. I think I did really well in saying that, by the way. I just want to throw that one out there. Who'll be talking through sort of the work she's done in just completing her PhD. We actually found Ioana after she posted about the completion of her PhD, which is an incredible feat. We were just talking about sort of the work that goes into that. So I guess the time is to sort of introduce you and tell us a little bit about yourself, your background, and sort of the introduction to your PhD and what you were looking at.
Okay. Thank you, Ioana. It's very nice to be here. Thank you for inviting me. And, it just shows that even a LinkedIn post can bring you somewhere to talk about your work, and
100%.
It shows how much it can help. So my entire background, I'm going to go back to my background, was in biomedical engineering. I did my bachelor's degree in biomedical engineering back at University of Polytechnica of Bucharest. Then I moved to the UK in 2019, and I did the 1-year master's degree in biomechanics and bioelectronics engineering. And that's where I started looking more into cardiology and hearts. We had these 2 modules which were taught by the same person, Professor Ashraf Kir. He was doing with us artificial hearts modules and biofluid mechanics. And I was more inclined onto this biofluid mechanics things because I found it fascinating how just a structure in the arterial wall can change everything. You're never going to go and say, I'm having a bad day. I think my arteries are stiff. You don't know. You're not going to do that. But arterial stiffness, it's actually very dangerous. And over time, it can lead to death. And I did my final year project with Professor Ashraf Kir, and I studied the B mode and D mode ultrasound images of the arterial wall, and we were looking into parameters that we can extract from images to assess the arterial stiffness. And this is nothing new today, but 10 years ago, you actually had to do an incision. And it was a highly invasive procedure to assess the arterial stiffness and the properties of the arterial wall. And it was fascinating that we could actually just do that with programming, with images that were very easy to take in hospitals. And at the time, Professor Ashraf Kir kept asking me if I want to do a PhD. I obviously said no.
Too much chocolate.
Yeah. No, I don't want to. I had this impression that the PhD is highly theoretical, and I just wanted to go out there and experiment, go into the industry, gain some experience. But luckily he insisted, and at some point he told me, look, I have this really cool project. The project was already defined. They had a proposal. They had full scholarship for it. And he just told me, can you please just take a look at this project? If you don't like it, I promise I'm not going to ask you anymore. But when I saw that project and I read about it, I was just thinking, no, I have to do this. I just liked it instantly. And I was interested in data science for a few years at that time. I didn't necessarily do it during my degree, during my modules, but I experimented with it a little bit at home on my own. And I just saw that as an opportunity to go and learn about it. And in a very cool field as well, in cardiology, something that I already loved doing. And that's how I got into this area.
If I take you kind of all the way back, like before your degree and everything, what kind of got you interested in kind of taking this route? Was it something you've always been interested in from a kind of a young age or anything like that?
I wish I had, a story, a very inspiring story, but I actually didn't. When I was at the end of my college, I had no idea where I wanted to go. I was actually training to go into the military school.
Oh,
Wow.
And I thought, okay, I think this is right for me. But at some point, I was, no, I don't think this is what I want. And I was lost. And I remember there's these people that help you along the way. And one of my teachers back in college, she was a very nice lady. She knew me very well. She was very supportive of her students. And she saw that I was lost and I was trying to find my way, and she came and she told me, you know what, I heard about this very cool area. It's biomedical engineering. I know you're really good at physics and I think you would actually like it. How about you go home and look into it? And that's how it all started. I never thought of going into medicine, not because I didn't like biology, but just because I thought I don't want to be a doctor. I don't actually go and cut people. I just didn't see myself doing that. But I was very good at physics, maths, and it seemed like this was combining the two. I was still doing biology, but applying everything that I knew on a technical level. So yeah, it's not very inspiring, but that's how it was.
It's still how it comes together though, isn't it? It's people get to different points in their lives with kind of different journeys, and that one person, like you said, that careers advisor or that professor has just kind of put you on this path, which is quite exciting.
It's just someone that needs to make that click for you, or give you an idea, or just, obviously she didn't force me to do that. It was ultimately my choice, but
I think that's something we can all relate to, right? We've all sort of been at that juncture thinking, what comes next? What do I do? And it's brought you all the way here on this sofa with us on the Effective podcast. I want to talk a little bit about the project that you started your PhD with. What was the sort of like the problem that was aiming to be solved there? What was the sort of like the hypothesis that was looking at sort of being tackled?
So the main aim of my PhD,
It's okay.
Was creating this temporary cardiac pacing simulator that can be used as a training tool for clinicians. You probably heard about pacemakers before, I'm not sure. So a pacemaker is implanted in patients and it stays there for the rest of their life, and is supporting the heart to have a proper conduction, to beat properly. Whereas the temporary cardiac pacing device is implanted in patients. It's an external device, so it's basically a generator that stands on the table next to the patient, and it's inserted in patients after cardiac surgery, because during surgery the cardiac muscle can be affected, and so the heart doesn't pump properly anymore. But that doesn't mean that patient needs a pacemaker. We can actually go in with this temporary pacemaker and help support the heart to recover its intrinsic conduction. However, current training in the NHS, and at least from what I know at Harefield Hospital, London, and even across the globe, it's not it doesn't have a good structure. So it consists of PowerPoint presentations, textbook, ECG examples, and very, very rare practical assessment. Which means that although these methods are good on their own, they are not sufficiently preparing the staff to optimize the settings, because this device, unlike the permanent pacemaker, which has automatic functions, this one doesn't. So there are a set of parameters like sensitivity, pacing mode, a capture that need to be set by each clinician, and they need to be nurses and clinicians need to check these at 12 or to 24 hours or even more in unstable patients. So it's very important that those are set right and tailored to each patient's needs. But because we don't have the necessary training, these devices actually end up doing more harm than good.
Because they need to be monitored so often, so closely, so you need
Yes.
more resources to do it. Yeah.
I don't think it's about resources, but it's about the lack of training
Okay.
here. So because they don't have the necessary training, they're not prepared to act in emergency situations, and they're not prepared to tailor these settings for each patient. So this simulator comes in and fills that gap. It's basically a platform at the moment. It's just a user interface that uses, at the base of this are real signals from Harefield Hospital, London. I acquired those signals, and additionally I created synthetic signals that can be used to mimic real clinical scenarios. So by using this platform, they will have a safe environment to practice as much as they need until they feel confident and without the risks associated with real settings. And they can just go at home and use the platform. They don't have to be in the hospital, and it's going to assist them into taking the right decisions and maybe doing more timely decisions when there's a critical situation out there and the patient suddenly goes into, let's say, ventricular fibrillation, or their heart stops altogether. Then they'll know what to do and how to fix that.
Just gives people more confidence to act, like you say, because that wasn't there with the lack of training and everything.
Exactly. A safe environment, and also it provides feedback. While they do and change the settings, the platform gives them feedback saying, okay, this setting is not right with this pacing mode because. And that's a way of them getting real-time feedback at home. It doesn't matter where, in the hospital, so they can learn about all of these scenarios. Yeah.
So what comes next for the platform? Are we seeing it rolled out on sort of like a bigger scale, or is it still sort of being used at Hatfield and sort of more centralised in that location?
It's not actually made available to the public, so to say. It needs to go through a lot more. We'll probably speak a little bit later about all of the processes that a product needs to fulfill to actually get into the NHS. It can be used locally by the clinicians that we collaborated with, but it needs a lot more work in a sense that I developed the techniques because there was a lack of techniques in this area, but the platform itself, it's very rudimentary, so I'm not good at user interface. And I'm not ashamed to just acknowledge that. It doesn't look great, it needs a lot more work, and but I think the techniques were the most important part of it.
So proving it's possible is the first step in making it a reality, isn't it?
Exactly.
Yeah.
It's a prototype. It's at the stage of a prototype, and I think there's a lot more things. So knowing so much about this project also makes me know also how much it lacks. The areas of improvement, like data diversity, and more testing and validation that's needed, because as I said, when I started, there was a lack of training, a lack of techniques that were needed to create this device. So not only I needed to create the technique, I then created the device itself. So it was like in stages. I first looked a few years into creating the right techniques, and then I included them into the simulator. Yeah.
Is there a level of sort of AI and machine learning that goes on within the platform that sort of helps the user in the training sort of react in real time to these signals?
Yes, the platform, the simulator, actually uses synthetic signals. These signals are generated with a GAN network, so it uses deep learning to change the morphology of the signals according to the settings. So that's probably the biggest area of AI in this project. But also we had that additional level of doing real-time classification for each heartbeat. But in our case, we used multimodal signals because we were working with not only ECG, but also arterial line blood pressure and central venous pressure. These signals are monitored as a routine in intensive care units. And they are not only that they are not as affected by noise as the ECG, but they are not as prone to movement as the ECG signal is. So for us, we saw that as kind of like I don't find a word, sorry, as an opportunity to go in there and create new alarm systems that are specifically designed for pacemaker settings by using these additional leads. So we are able to not only classify arrhythmias, but also classify different paced settings. And in previous works, you'll go and see, oh, okay, they classify this as a paced beat, heartbeat, but they don't say the settings of that heartbeat. But we are able in this device to have approximately 15 or 16 classes of different paced settings. So it's going to be the next level of adding this technique in those specific devices, so that you can straight away just tell the clinician that actually this is not the right setting. So at least that's what I hope for.
Obviously, the whole world's talking about AI and everything at the moment, you know, in every single kind of aspect of our professional and personal lives.
We had a conversation about it earlier in the office, and sort of adopting AI as a tool, and
I think you can take a picture of what's in your fridge, and it can tell you what you should be cooking for dinner. But bringing it back to kind of cardiovascular kind of treatment, how do you see like AI like affecting this world? It's only going to get bigger, isn't it?
It is. But I think it's going to go slower than we see it into the general public and in other industries.
Is that from like an ethics and regulation point of view?
Yeah, definitely. AI is already making an impact in the hospitals out there and is assisting doctors into taking the right treatment decisions, into diagnostics, prevention as well, in prediction of alarms, and in imaging techniques as well. However, all of this progress is a lot slower because we need to make responsible decisions. It's about human life, it's about our life. So when you take a decision of using an AI system, you have to look very carefully in things like ethics. Is the data biased or not? Because the AI is just as good as the data you're training the model on. So garbage in, garbage out. You know, if your data is biased towards men or towards women, why not? Or towards specific ethnicities and demographic groups, then your model will obviously be biased towards that area. So it needs proper training. Moreover, there's the FDA approvals that a model has to go through, and because AI, it's not. Fortunately, actually, AI, it's not excluded from this area, and it takes years to do that because it takes a very long time to go through this process. And lastly,
so the models themselves have to be approved regardless of everything else.
Yes, of course. So, and for a model to be good, it needs to be explainable, transparent, obviously ethical, unbiased, and all of that. I think that's actually generally the case for everything, but including a model into the NHS is always going to be more difficult because of the additional regulations. And lastly, you need to make sure that model is going to be fit for purpose, and also it's able to be included in the existing pipelines, into existing workflows, because a model might work perfectly on a lab or on your personal computer, but you need to make sure that's not going to disrupt the current processes, and you need to add it into the existing systems. So it needs to be kind of good enough for that. Or not necessarily good enough, I think that's not the right term, but it needs to
Fit for purpose,
fit
right?
for purpose, yeah.
How do you, when we're talking about sort of biases within data, again, this is something that we talk an awful lot about. How do you ensure that data is good data? Sort of how do we go about ensuring that we're not putting garbage in to get garbage out?
Well, there's different ways of doing that. First and the most obvious one is testing the model on different metrics, and not only testing it in general, because we can talk about a model being accurate. Oh, I have a model that has 90% accuracy. First of all, accuracy, it's not a very good metric, but also if you have 90% of your data comprises of sinus rhythm, which is normal rhythm of the patient, and your model it's detecting that accurately for all of that population, that's already 90% accuracy, right? But it's not going to do anything for the other classes. Obviously, we have imbalanced data sets into the real world as well, but you need to make sure that your model is you can either do that through data, so having a data set that's balanced so let's say you have 5 arrhythmia classes, you'll have 5 equally distributed data points for those. But you can also do that from the architecture of the model to make sure you're putting more weight and emphasis on the imbalanced classes, so that the model also learns how to classify those. But you can also go and look at different demographics. So when you're doing this analysis, you can go, okay, are the true positive values? So let's say if we have, for example, if we're detecting atrial fibrillation or heart failure, we want to see, was heart failure predicted fairly? Did we have the true predictions equally distributed across all group of demographic patients or all group of genders? So you can look at it from this point of view and just do a thorough analysis to make sure that your model is not biased.
We have a responsibility to proactively kind of address that bias. I think there's no excuse now, to not be aware that the bias exists. Certainly at Meet, we've written content about kind of certainly like the underrepresentation of kind of the black community in a lot of trials in the US. So we know that happens. So moving forward as an industry, we've got to be proactive in trying to address that. If we know we're not getting enough data from certain communities, certain demographics, whatever they may be, is we've got to try our hardest to fill those gaps and make it accessible as well to get that data, because sometimes it's hard. Certain demographics, might not even be aware that their participation would be useful. So we've got to do a lot of work around education, not even just getting the data.
That's true. It's important to get the data. It's also important to look at to kind of look at these groups individually as well, especially from a healthcare point of view, because you might think that, for example, in traditional medicine, you'd use specific thresholds. And I think you already know that when you go and do your blood tests, they'll look at specific thresholds and say, okay, if you're under this threshold, then you are at risk of you're not at risk of developing heart conditions, heart failure, or if you're over that threshold, then you are at risk. But if you're going to go in maybe Asian cultures, you'll actually see that that threshold is a lot
Changes,
lower
yeah.
because they are generally healthier than we are, right? So you have to look at things like that too. Because if you take
One person's
someone-
normal isn't another person's
right,
normal.
100%.
is it?
Yeah, exactly. So that's why it's important to have this well-distributed data set and also look at individual groups. Yeah.
Mhm.
I think that's the thing with AI, like the speed at which we see AI evolving and developing. We've got to put things in place to make sure that that misrepresentation, underrepresentation doesn't grow at that same speed, right? We don't want that gap to get bigger.
Because it will become the truth. That's the
That's
challenge,
the
isn't it?
issue, right?
Yeah.
Because when it becomes that a known commodity, it's an awful lot harder to work back and sort of like, I mean, we see
We've seen that in society.
we
for
see
the
it
past-
all
Yeah.
the time. So I mean, we could talk for hours about that. I'd like to talk about the future,
Yeah.
not just in general, but as this research grows and expands, where do you see it going within the next 18 months, 24 months, 5 years, 10 years? Do you think we can get to a point where we could sort of build AI models that could spot these inconsistencies, issues with the hearts earlier, and without sort of like a margin of error, that we can just go, okay, we know this is happening because the platform has told me this is happening. We can just go in and make that and do the procedure.
Yes, AI is already used on a quite a large scale currently on prediction, and we do this in hospital already from short-term prediction, like having ICU monitors firing an alarm 5-10 minutes before an atrial or ventricular event, to up to very long periods like 5-10 years before, but that's more like the preventive one, so risk associated with developing heart failure, for example. And I do have a good example for this. So currently, actually, a group of researchers from Oxford University. They all are also founded by British Heart Foundation, so they are there with me. They created an AI model that can actually analyze CT, computer tomography, CT images and scans that are already routinely done in patients that come in with chest pain. And they can predict heart attacks in this group of patients up to 5 years by looking at things, extracting things like very small scarring, inflammation, or changes in the structure of the coronary arteries, the arteries which are responsible for providing oxygen and blood to the heart and help it work. So we can already do this, and this helps because we're not only there to treat, we can actually prevent these cases. 1/3 of this population that was coming with chest pain in the NHS were going home thinking that they don't have anything, and then they will come back with a heart attack after a few years, or it turns out that they had a heart attack that maybe caused their death. So we can use this to prevent and have early treatment, and it's a lot better to prevent than to treat, obviously.
Yeah.
Yes, so, and I think medicine will go even more further than this. Would be fantastic to know at your lifestyle, let AI, well, maybe, I don't know. I mean, our watches are currently taking signals from us and a lot of data. Maybe sometimes in the future, you kind of like vibrate and tell you, actually, my heart
we need to call a doctor right now.
Exactly. You might have a heart attack in the next 5 years if you keep doing that. I don't know exactly if it's going to go to this stage very soon anyway.
Like you say, a lot of the, wearables now, sometimes I don't think we consider how much. But we're both wearing a Garmin here. There is an insane amount of data that these companies are collecting. Garmin, Apple, and plenty others. And you do wonder, could all that data be, does it get shared, like anonymously? Are we, using that data to inform, the future health? I'm not sure. I don't know. They might be, but I don't know.
I was actually looking into this.
Yeah.
Because when I bought this watch, I was thinking, oh my God, can I actually access this data? How cool would it be to develop models that are specifically tailored for me?
Right.
But I couldn't. I don't know, if you find a way, just let me know.
But that'd be the goal, right? I mean, I've had conversations with people who are working in the States. A chap we're speaking to at the moment for a future episode of Affected, talking about this idea of one medicine for one person and having truly tailored healthcare. And you look at the speed AI is going. We are talking about the data that we are collecting on a personal level.
Yeah.
It isn't too ambitious to think that somewhere down the line we could treat on a person by person basis, and hopefully at a cost point that everybody can access, because again, the stuff's getting cheaper as we get further along down the line, right?
Well, yeah, I can't remember the guy's name, but the famous guy, the American guy who has spent a fortune on his own health to kind of stop aging and take many supplements. Obviously, that's kind of an extreme to kind of stop anti-aging, and it doesn't seem like, from what I've read and kind of absorbed, that he has much of a life because he has to do so much. But a lot of that will be based in kind of research and understanding and monitoring every probably data point in his body, and obviously he's got the budget to do this. But like you say, the speed of innovation in the life sciences is insane.
And listen, on sort of like a person by person level, the layman out there, I mean, if better data and sort of better use of AI can buy an extra 6 months or an extra year with a loved one, that's all that really matters ultimately, on sort of on a real world sort of application of that level. That's the reason we talk about the people we work with on a daily basis, and the one great thing about life sciences is nobody's here by accident. Everybody who I've spoken to, who we spoke to, and we have these conversations with, they're in life sciences because they want to fix a problem that is important to them. And I feel that the right people in the right places, people like yourself doing the amazing work, and an opportunity to talk about it here, which is awesome. What's next for you?
Oh, for me, I think at some point I'm thinking of probably going back to this project. I just felt like at this point in time I needed to go a bit outside in the industry, to explore more, to see exactly what the next step is for me. I hope that even if they do this project and my team continues it without me, I promise that I'm going to be there to assist the next person into continuing this project. And I really hope that at some point it's going to become a product that's used across the NHS. I already know the new techniques that could be applied for it, but I felt like for me it was the right time to explore a bit outside. And in the last year of my PhD, I was recommended by Alan Turing Institute for this data scientist PhD internship at HSBC. I had an interview and I got it. And for me, it was just a way of exploring new types of data, knowing more, maybe new techniques.
That diversity of kind of ideas and new industries only going to benefit you, isn't it, moving forward?
Exactly. Sometimes you're so into your project, it's really hard to go and see outside the box to see what does really matter, or what is the different approach that I can take. So sometimes I remember when I was stuck and then doing something, and sometimes in research, you do a few months, 5-6 months, you would do something, and then you realize that you're at a dead end and you need to start again. It can feel frustrating, but it's obviously giving you the right experience to go and try something new again. But going a bit away from your project always helped to come with a fresh mind, new techniques that you could try, and just have a new perspective over that project. Because you were the only person that knew so much about it, so it was really hard to detach from the project. But I think this year or so away from it, it kind of like gave me that different perspective of how can you go with this project and do the next step. How can you validate this? So it helped me look at it in a more practical way, kind of like business style, you know, 'cause obviously in corporate, you're looking, okay, we have to make this project bring us some money. How do we actually do that? How do we validate? How do we ensure that if we add it into current pipelines, is actually gonna bring us a consistent outcomes and consistent output?
Amazing.
Yeah.
I always like to end these episodes with a little bit of advice. So if you were sat speaking to yourself at a younger age, or any aspiring I know, right? Researcher, engineer, someone who's starting that journey, what do you think is sort of a key piece of advice that you would impart to them and sort of helping them on their way?
I think the most underrated quality in an adult is the ability to do what you don't want to do in the days that you don't feel like it. Because especially during my PhD, you have a very flexible schedule, right? No one asks you to wake up at 7 o'clock in the morning or 6 to go and do the work that you have to do, or keep trying the same thing you've been trying for the past 3 months to achieve. No one is there. You obviously have constant meetings with your supervisor, but especially while working from home, for example, because I started my PhD in 2020.
Yeah,
so
right in the middle of it. Yeah.
Oh my God. It was so hard to actually get the right ethical approvals and get the data. And no one would come and tell me, wake up, it's 7 o'clock, you need to wake up to go to work. No one. But I think what actually helped me was that that self-discipline that I developed along the years. And that's what kept me going even when things weren't going my way. Especially in research, it's hard to control that. But persistency and discipline helped me the most. And I think if there was something that I would tell myself like 5-10 years ago, it would be probably not to be afraid in just doing the things that you think will bring you value. Because when I started my PhD, I told you, with Professor Ashraf Kir, I didn't actually think that I'm going to be able to do all of this thing. I was like, this is even the project that he gave me. When I went to him, and he was also the director of the course, and when I went to him to ask for a project, it was a different project than the one I had with the ultrasound images. He was like, I think this project is too simple for you. You have to step up, and now is the time. And I told him, no, I'm afraid I'm going to fail if I take this project, because it seemed a lot more complicated than what I knew to do at that point in time. And he gave me really good advice. He was like, you have to go outside of your comfort zone, because you have potential more than what you're doing. So sometimes being a straight A student is not enough. You have to go outside of your comfort zone, not just doing it for that straight A, for that A+ and distinction. You have to go and go out of your comfort zone, challenge yourself. And even coming here today was a challenge, because I'm not used to being in a studio and
you've been amazing.
recording. Thank you. But when it's challenging and when you feel a bit scared of doing it,
it's probably right?
Yes.
Yeah.
Definitely right. So that's something that I would tell myself, my younger self.
Yeah. I think, Glenn, I'd also like to ask you on this, because we're sort of, we're talking about AI an awful lot, and again, we literally had a conversation before we started about sort of how do we look at embracing AI, maybe steering away from it in different situations, what would you say? What would your advice be in sort of like looking at AI models and sort of and using AI as a tool sort of going forward, because it is becoming more and more prevalent in everyday life?
Yeah, it is. Obviously, when we left the office, we asked everyone around is like who's using kind of AI in any form, and pretty much every hand went up. Mostly probably around ChatGPT and to make sure spelling's correct. But I think I think ultimately the view with anything AI is that it needs to be an enabler. It needs to be kind of an extra limb that helps you achieve what you want to do. I think the key for me with AI is that yes, it might do things quicker. In some cases, it might do them better. But when, as you were saying earlier, when there's kind of humans involved, it's still got to have a focus on the experience of who's on the receiving end of the AI, and they still need to, feel valued, and they still need to feel kind of seen and listened with whatever you're doing, whether it's something as really complicated and really important as medicine, all the way through to some of the work that we do at Meet from from a recruitment, from a talent planning point of view. It all has its place. So I think it's a case of see where you can make yourself kind of more efficient to retain the human touch, I think, and
that's something you can't replace, right?
No, you shouldn't be. You literally can't, can you? You can't replace it. I think I don't think we'll get far away. I think certain things will become kind of indistinguishable at points, but yeah, ultimately, it'll be very hard to replicate something like this. I promise we're not avatars.
I think to add to that is that I don't think in medicine, at least, as you said, you need the human touch. You need the empathy that a doctor could give the patient, the 360-degree view that the human touch can provide. So when you take a decision, you're not going to only look at the data, right? That'll be definitely very wrong to do. You have to look at the data, blood tests, patient history, how they feel. You need to take in consideration also
how they're acting in front of you, demeanor, isn't it? Body language can play a part. Yeah.
Exactly, or their current circumstances, because you can't just ask a patient to do a specific treatment without considering their circumstances. Life is different for everyone, right? Or maybe some couldn't afford this treatment, so you have to have all of the data. And I think this is something that only a real doctor could do. The clinical experience is something that AI, I don't think, will be able to replicate, at least not in the next 20 years, or at least, and I'm saying at least.
In medicine, do you, like AI, robotics is another one. Do you think there'll be more usage of it in like surgery potentially? I feel like surgery is a place which is quite ironic, really, considering surgeons
talking about human touch, right?
Best of the best in that sense. Highly technical, very precise. Literally have people's lives in their hand. But it feels like the intricacies of surgery and that preciseness is something that can be probably more replicated by robotics, AI, and stuff like that.
I think we already have that in medicine. So that
there's
have
remote operations happening and stuff as well, isn't there?
Yes. But I think it's a better use of robotics and AI when it's used into the current tools that they have, so that they can guide them and help doctors make the right decision during the surgery. And this is obviously based on imaging in highly advanced image processing and
the image is
AI
being
based.
created utilizing AI.
Yes. So during the surgery and during that incision, the doctors are guided. So, for example, we have for catheter operations, you have those robots, and they provide like millimeter precisions. So it's definitely out there already, and I hope it's going to be added a lot more to just help doctors go into the right path, or if something unexpected occurs, let's say something that they didn't see on MRI or CT. So at least the doctors will know not to go and release a blood clot into the bloodstream or things like that, and that's definitely going to happen a lot more. Yes.
I guess all that's left for me to say is a huge thank you to Glenn.
Thank you very much.
As always, co-host extraordinaire. And thank you to Ioana for joining us here today. We found out earlier is actually a Brunel alumni, so there's a little connection there. We did win the national championship earlier today. I wanted to get that one in there, so little Brunel pride in here. We've taken a month off here at Affected recently, and sort of just to look ahead at the future of where we're going. We've sort of been talking about what a season 2 of Affected would look like rolling into 2025, and we've got some incredible guests lined up, more incredible conversations, and I think it's a good time to sort of announce that we will be hosting our first ever in-person live event in London, which will be a follow-up of our white paper that we released 2 years ago, and following a year on from our Women in Leadership Live roundtable. We've got a fantastic slate of speakers who I probably can't announce right now, but will be over the next few weeks. And keep your eyes peeled on all of our socials for more information about that. Always point to the socials. Give a call to action. See, Glenn has taught me very well. Again, huge thank you to you guys. Absolutely love this conversation. It's so interesting to talk about what the future of healthcare might be, and sort of what the implications are for everyday people, and to hear about the amazing work that people like yourself is doing. So please join us next month, and we'll see you again very soon. Thank you very much. Bye.